to be a pioneer in it for us than Dr. Anu Kinney. Steve Alexander, one of the chiefs, will do a little bit more formal introduction, but she's been a pioneer throughout her life in cardiac cath, which I think is probably one of the hardest areas in all of medicine for women to succeed in, both because of the hours, because of the challenges, because it has been historically a man's world. And she's elevated women in cardiology, women in our cardiology department to a new echelon that hadn't been achieved before, both by personal effort, by sacrifice on her part, and leadership, which has been extraordinary. She continues to be extraordinarily productive clinically and extraordinarily productively research-wise. There was just an article in looking at CRP and its risk factor gradation in patients with coronary disease that she was first author on. She's also been a pioneer in many apps which are unique and distinct, which really opens up the field of cardiology to people far and wide who don't have access to the clinical education and quality of education that we have here. So I wanted to thank her for being a pioneer for our virtual panel discussions during COVID, and hopefully there won't be too many kinks in it. Without further ado, I want to introduce Steve Alexander, who's going to more formally introduce the conference.
Thank you, Dr. Goldman. I just want to echo everything Dr. Goldman said. In addition to all that, Dr. Kinney is also the director of the cath lab, and she's the director of our structural heart program. So thank you, Dr. Kinney, for being here. Briefly, I just want to mention the other members of this panel. There's Dr. Sahil Kara, who is the associate director of the structural heart program. We are joined by Dr. Phil Sufi, cardiac surgeon, professor of surgery, who we work very closely with. Dr. Mohammed Al-Kazaz is on the panel, who's an expert clinical cardiologist, someone we go to with all sorts of clinical problems. Dr. Gilbert Kang, who is the surgical director of the structural heart program. And of course, we're joined by our leader, Dr. Fuster on Zoom, who is the director of Mount Sinai Heart. So thank you very much for being here. Thanks, Dr. Kinney.
Yeah, good morning, everybody. Thank you for the introduction. There used to be, like Dr. Goldman mentioned, live, where everybody used to be together, but I think first time we are trying this kind of a virtual. We are also joined by Dr. Sharma. As long as he has time, he'll be with us. So the way this format is going to be that I'm going to give a little bit of introduction, some slides to show you some data, and then we will have the panel give their experience based on their clinical knowledge as well as their, the data that has been presented. So the topic for today will be, transcutaneous aortic valve replacement, which is becoming the gold standard actually for patients with aortic stenosis. So I'm going to go with a little bit of history, incidence, clinical presentation, then go with the, TAVR itself, and then what is the update in antithrombotics in patients who are having TAVR. So just going back with aortic stenosis based on 4 valves that we have, the normal is about 3 to 4 centimeter, but here I think very important for all the fellows as well as any medical students who are listening to us, that when it is less than 1 centimeter squared, we call it severe, less than 0.7, we call it critical. Etiology is very important for us when we see these patients in the clinic, which is usually unicuspid. We have probably done 2 cases of unicuspid, but bicuspid we see, and most of it very rare, maybe rheumatic, and today actually we have a case of rheumatic aortic stenosis that we are doing a cath. Then more acquired. This is the incidence that everybody should know when you're seeing the patients in your clinic, that when they're calcific, about 5% at the age of 70, 10% at age of 80, and look at that, at 90 years, we are seeing this population now because of their aging, but they're still very healthy, and we see them. And this is the Braunwald good old publication which has been there, and we have learned this in our medical school, that once they have symptoms, which is dyspnea, angina, when they have syncope or heart failure, then the survival is poor, and to date it is still true. And this is an old guideline, 2006. I just want to show you what this could be. I think we can go like this. Yeah, the flow chart, which is old, but I think this is very important for us to know that once we have diagnosed clinically, then whether they have symptoms, when they have symptoms, of course, it's class 1 for treatment. When they have no symptoms, we do wait and watch. This is what I think based on that, the surgical recommendation was that patient should get aortic valve replacement. So I think going back to the panel now, we have Dr. Fuster. If you can give us a guideline that when you, or what do you do when you see these patients in the clinic, what are the, I would say, when you examine the patient, because I know the current trend is that most of the people jump immediately to echocardiogram, other kind of diagnosis. I think what is it that that you see in these patients, whether it is a pulse and what kind of murmur that we are looking for in this patient diagnosis, because I think to date still people should not forget that the patient, talking to the patient, evaluation of the patient is a key. Dr. Fuster?
I don't want to bother you with a lot of information that you already know, but I will say to you, 3 things come to mind, which is what is evolving that is new. Number 1, I think stress testing is important. Many patients don't have symptoms and they present in some category of aortic stenosis. I want to know blood pressure response to and symptomatology on exercise. So that's what the first thing you do, and do you do this with echocardiography.
Okay.
A second issue that I think is quite important is what are the comorbidities of these patients. One of the first comorbidities that I actually look at the possibility of amyloid. As you know, about 12% of people, or even 15% of aortic stenosis have amyloid. So I look at the electrocardiogram in terms of the voltage, and I look at other possibilities, right bundle branch block, etc., that could give you a sense of whether or not there is amyloid. And then the question that perhaps quite important is that today we tend to intervene people much earlier than before. So the presence of the left ventricular mass in quantifying left ventricular mass, it tells you just to get there maybe earlier than symptomatology and so forth. These are guidelines that I'm giving to you as I think the patient will present to me with aortic valvular stenosis.
Okay. I think whatever Dr. Fuster mentioned is just here. Essentially, you're saying that if you're not sure that you do exercise stress, decrease in blood pressure, no augmentation of blood pressure in this patient, then you consider something has to be done to these patients. But this is the update of 2014 saying from symptomatic, we are actually moving to asymptomatic, and I will show you data a little bit later. This is where the valvular heart disease is moving, that asymptomatic but preserved LV function in this case. So based on all this, I think some people always have a dream. They always say that this is what happened. Anderson was the first one, 1989, who made this valve, but Alain Cribier, who is actually called the father of the transcatheter valve therapy, was the first one who first in man study, April 16, 2002. Based on that, then we had the approval for this cases. And very important, before we start doing percutaneous therapy, I think one thing that we base it is on what is called as a surgical risk calculator. So I think I will ask Dr. Tang, who is our surgical director, saying how important this is, as well as Farzan Filsufi, who is a surgeon, that how much importance they give to this risk calculator, STS.
Well, the STS score captures the different medical conditions of the patient and the age, and also the urgency of the procedure, any concomitant valve disease or coronary disease. And based on that, based on hundreds of thousands of patients that had surgery before, they calculate a composite score. And that calculator has evolved, from 10 years ago to now, because surgery has also been better. And you can see now in this graph here that the most recent guidelines in 2020 has basically recommended that irrespective of STS score, patients with symptomatic severe aortic stenosis can be considered for TAVR if appropriate. And that's where the STS score now, in my opinion, is more looking at the medical comorbidities of the patient in terms of the procedural risk of the TAVR itself. So patients such as advanced COPD, chronic kidney disease? Do they have concomitant coronary disease that need to be managed? I think those are the things that need to be looked at. Of course, STS score and Bartholomew can expand on it. Does not capture some of the comorbidity that is not included, such as liver disease, such as cancer or any kind of immunocompromised state that is beyond what just a simple being on steroids. And of course, the physical condition and functional aspect of the patient called frailty. So Farzan can
yeah, just to add a little bit to what Gilbert said, surgeons got interested in risk stratifications in the 1980s, and there were multiple risk factors such as Parsonage, Cleveland score, and so forth. And finally, we got to the STS scores. So it is a great risk stratification, at least gives some ideas about the risk of your patient, but there are two significant limitations. One is what some of the risk factors are not included, as Gilbert mentioned, such as, for example, liver disease or pulmonary hypertension, right ventricular function, which is a strong predictor of outcomes. The second limitation of STS risk factors is that it includes hundreds of thousands of patients from thousands of centers. You should know that at the peak of aortic valve surgery, an average heart surgeon in the United States was doing 10 AVR per year. So the risk stratification is overestimating the data. So when you, for example, the moderate studies was coming out, or the high risk, when you look at the outcomes in great centers such as Cleveland, Mayo Clinic, or other academic centers, their mortality was 50 to 70% lower than the stratified risk by STS. That's something that needs to be taken into consideration.
So this just gives you an, see there what we were talking about, so it gives you a number, and based on that we stratify them. Less than 3 is low risk, 4 to 10 is intermediate risk, this is high risk, and here you see that extreme, but it also gives you that low risk is majority of the patient, about 30% of the population we see, 20, 20 and 20. Mohammed, what is your experience in a clinic when you see these patients with aortic stenosis? Is both examination to when you refer to call the surgeon or us?
Yeah, definitely. So the first thing in any graph for all the guidelines is to see if it's actually severe or not, which is the first important point clinically to decide whether the patient's symptoms are driven from AS or other conditions. As Dr. Fusser said, coexisting cardiomyopathies, particularly amyloid, among other things. So in terms of determining the severity of the AS, the first thing is the physical examination, and the most commonly being the late peaking murmur obliquating S2 with radiation to the necks, along with the parvus and tardus pulses, which sometimes can be discordant and concordant with your echo exam. So if your echo, for example, shows moderate AS and your physical exam showing severe AS, it does not mean the echo trumps the physical exam. It means you might need the tiebreaker, whether with cath or whether with CT, something to help truly assess the severity of the AS, because that will have implication. Because on echo you could have improper measurements, or you're not catching the transaortic velocity the highest appropriately. And then in terms of echo itself, you have to have in a center where you have the technicality from a tech standpoint and the attending standpoint to look for it using right parasternal views, because you have a portion, like 25% of patients, I think, or so, could miss severe AS by not using right parasternal views. So the point I'm making here is start by physical exam to determine the patient actually truly has severe AS. Your physical exam might over or under. Echo might supplement that physical exam, but does not override it. And if you're unsure and you have discordant data, use other supplementary tools. And lastly, make sure, trust but verify, make sure all your data points are correct. And if you think it's severe AS and it's whether asymptomatic, using other methods, stress testing or BNP to see if there's a correlation with that, or if they're symptomatic, to refer for interventions based on their risk for the surgery or TAVR, their comorbidities, and the expertise you have. For intermediate and high risk, I think, especially above the age of 65 or 70, we will lean more toward percutaneous interventions. But in the low risk group, even though the guidelines suggest we go like a kind of TAVR should be considered, it's a little bit more detailed. I think we're going to go into that later.
So based on all this, you see that after the approval from 2010 to 2019, where we are, from prohibitive risk to high risk, intermediate risk, low risk, everything has been approved. And 2 valves that are available right now in the United States, which is, we'll show you those valves, SAPIEN as well as SAVR. So now this is what the guidelines show from class 1, where it was prohibitive surgical risk was TAVR, High was surgical TAVR AVR. Low was something that we said should be getting surgical AVR. Even that has become TAVR lately with all the approvals. I think we went over this a little bit, imaging for TAVR. I think I'm that based on clinical exam, you make a diagnosis, okay? Ejection systolic murmur, aortic stenosis, not pansystolic murmur, no MR. So let's go. What is the next imaging that we are going to do? Why this is important is what is called as the whole thing revolves around what's called as the heart team, which most people are here who are part of the heart team. So the heart team sees the patient and what all things do they need before we say, okay, this patient should go for TAVR or this patient should go for SAVR. So echo we have discussed. I think there's one other extra test that we are, we will need for this patient, which is a CT scan. And a couple of the patients will need maybe carotid or maybe pulmonary function test. So Sahil, tell us, I think they have discussed everything about echo. Give us some update, what is it that you're looking for in TAVR CT that will tell us, okay, this patient should get TAVR versus SAVR.
So CT has, in the last 2 to 3 years, has really picked up in our, AS cases. Used to be TE for the most part back in the early partner trials. We look at two things. One is we want to look at what access we want to take. The benefit of TAVR comes from using a transfemoral access. Any non-transfemoral access, it beats the true benefit accrued from a TAVR procedure. So you want to look at if your access is feasible from transfemoral or not. If not, what other options do you have? You have subclavian, carotids, you need to do a transfemoral cut down, you want to go transapical or direct aortic. Direct aortic transapical has sort of gone out of favor. So we want to look at the groins, you want to look at the iliacs, you want to look at the aorta and see if TAVR is essentially feasible or not. The other thing you want to really look at is the aortic root and the annulus. Is the valve very severely calcified? If the annulus is calcified, the LVOT is calcified. Is it really safe to do a TAVR in these cases? Or whether we should proceed with surgery? If the valve is too small, should we go for surgery with a root enlargement rather than trying to put a TAVR valve and cause patient prosthesis mismatch? So you want to look at the groin and you want to look at the aortic annulus and the coronary height. You want to make sure the patient is safe for a transcatheter procedure. If not, then the patient should be going for surgery.
And also, I think, like Mohammed mentioned, if there's a questionable whether it's a tricuspid, bicuspid valve, I think CT also will help us. Anything else you need to add, Gilbert?
No, I think just to, in addition to that, now that the 2020 guidelines basically TAVR is indicated across all surgical spectrum, everyone with symptomatic AS should have a CAT scan.
Yep.
That way we know which therapy will be best for the patient. I think that's really what the take-home message should be.
So when what we are trying to say is that when you diagnose somebody with aortic stenosis in your office, they should first come and see the heart team. And in the heart team, we will probably confirm with the echo, do the CT scan. Then we go to the final, which is the coronary angiogram to make sure there's no concomitant. One other thing, so far we only discussed patient with normal EF. If the EF is less than 50, you can consider a dobutamine stress echo in this patient. So based on all that we have discussed, look at the previously extreme high risk, intermediate low risk. Right now the current contemporary practice is high risk or lower risk. Why? High risk most often I will tell you, I would say surgeon is somewhere in the hospital, but when it's low risk, we want surgeon nearby in the room, and we want to make sure there is bypass machine in the room if something goes wrong. Otherwise, for other risks, we don't need it. Going back to these are the two valves that have been approved. Sapien or core valve, we always hear from us that once the procedure is done, we always text you or call you saying successful this and these procedures have been done. Dr. Sharma, is there anything else you need to add for any other valves that are, new valves that we have or, valves that have been out of the market now?
Yeah, no, we have been trials. The third one approved was Lotus of the Boston Scientific, but they had a little trouble in terms of release and creating some catastrophe. That valve has been withdrawn now. So that is gone. So these are the two. And the other Accurate Neo, we are part of the trial. of that's ongoing at present. And so still, I think next couple of years, still these two, their reiteration, their latest generations will continue to evolve and dominate the market. Although outside United States, another 4 or 5 valves are available, but in United States only 2.
So I think the approach for the TAVR, we just said, the key is that these patients have to have the procedure transfemorally, and all the other various route I think Sahil just discussed, but I think our goal is to do transfemoral, and many times for transfemoral we will try to do it with some kind of modification. We may have to do a PTA if there's a lesion there. Sometimes we ask a vascular surgeon to give us access, and nowadays we have what is called as IVL, where we do this special balloon so that we can take care of the calcium as we are going up. So we know that we are discussing a TAVR, yes, low risk, everybody should be getting TAVR. But what are the issues that we think we do face with the TAVR before, we have the surgeon who will say probably we should be doing SAVR, and we will say no, we should be doing TAVR. So this is the newest update saying that the important complications, so always you remember 5, okay, the important thing that you need to be worried. Why this is also important? Because as a cardiologist, when you are seeing these patients in your office, you will have to discuss, because many of them want to hear it from you, what is the best treatment, okay? Is it surgery or is it TAVR they want? So PVL, and of course, most important thing, even they could be 85, 90-year-old. One thing patient tell us is that I do not want to have a stroke, okay? That they have a good quality of life. Why they want this treatment? Because the quality of life is what they're looking for. And the quality of life all depends on the stroke. Even if they say that I cannot, my thought process, my thinking has gone down since the procedure, they do not want to have that. So the cognitive decline is something also they do not want. So that is very important. So going back to Sahil, what is the thing that you think, though, that we will, based on the CT scan, that will focus that yes, PVL is something that we will see in these patients?
Right, so definitely you want to look at the annular LVOT calcium. You want a valve that is too deep or too high can cause PVL. If there's a lot of calcium, the valve might not seal properly, so you might have PVL. Previously, we used to think that moderate plus PVL, leads to overall poorer quality of life. But recent data tell us that even mild plus PVL can lead to a functional decline. So if you're looking at a low-risk patient and you think the risk of PVL is very high, then you should consider SAVR in these cases, because they're definitely going to come back to you in 2 to 3 years, and you will be offering them surgery at that point. So it is better to consider that upfront. So you want to look at the CAT scan more closely. In a very high-risk patient, mild to moderate PVL, yes, you would take the risk because you'll give the patient symptomatic benefit. But in lower-risk patients, you should be very cognizant of PVL.
We have 2 valves, right, Gilbert? Is there a difference based on the calcium of LVOT or annular calcium between the 2 valves that we have when we select?
Well, the balloon expandable valve works by inflating the balloon, and valve expands against the radial force and an anchor. So the challenge of a lot of calcium in the annular LVOT is it can disrupt that anatomy and cause what we call catastrophic annular rupture, which would need most of the time surgical conversion with a very high mortality. So typically those who will use a self-expanding valve, which is a little bit more forgiving and malleable. Having said that, the advantage of the balloon is the radial force. So if there's a lot of calcium in the leaflet level, like a bicuspid, we may tend to use that to allow less likelihood of residual PVL. So that's what we have the Harkin discussion looking at together, and also based on the patient's procedural risk as well. We might trade off a little bit more PVL rather than a catastrophic complication.
Mohammed, what do you tell the patients who you're seeing, patients with aortic stenosis, knowing that both surgery as well as TAVR have issues?
So it depends. Intermediate and high risk, unless they have a really, so intermediate and high risk, if they don't have, I lean toward TAVR. above the age of 65. If they're younger, of course, we're talking about surgical interventions, whether Ross or traditional surgery and whatnot. You look at the aortic root anatomy, aortic surgery, concomitant valvular disease, CAD. If we have like multiple, like three vessel disease plus multiple valvular disease, and they're like intermediate risk, probably more towards surgery. But in general, let's say it's isolated aortic valve disease, and they're intermediate and high risk above 65, more toward TAVR. Low risk, even though the new guidelines do suggest that TAVR should be the front line, I'm still like not 100% in that direction, because the partner 2 we have up to 5 years follow-up, and they're kind of non-inferior, even though there is a trend toward more valve thrombosis, even though with all definitions. Partner 3, I think they had their 2-year follow-up in ACC last year, which was reasonable, but the problem is with younger people, let's say 65, with PVL being an issue or durability of the valve. For low-risk patient, I think still more discussion between patient and the heart team to discuss. For intermediate and high risk, unless there is a good reason for surgery, more toward TAVR. Lower-risk patient, we talk more SAVR being a possible option, especially in younger people, more towards 65. 80 and above, of course, is straightforward, more toward TAVR. But low risk, I don't think it's, even though the guidelines recently more toward.
Yeah, I think we need to talk about basically younger versus older patient, as what you said earlier in that slide previously.
Exactly.
No valve, prosthetic valve lasts forever, right? You know, we all know even surgical tissue valve, maybe, you know, depending on your age range, the durability varies. So a 75-year-old, as far as I know this, the durability is still be longer than someone who's 65 or younger in terms of durability, and that's been well known in surgical literature. This is going to be the same for TAVR because it's the same tissue. So the question is, how many surgeries would this patient need in their lifetime? I think that's really the discussion, and we do that by looking at the CAT scan. So Sahil and I looked at it together, saying, well, maybe we're better with this valve because it'll be likely maybe he can get a repeat TAVR later on, versus this is not going to be possible. He needs surgery. Does the patient want surgery when they're almost like 80? Or do they want a surgery now, then they have a TAVR later? I mean, that's really the discussion that we have as a heart team with the patient.
My question also to you is, like, do you factor valve in valve when you present your data to the patient, even though it's kind of more experimental at this stage as a future option?
Yes, you have to. Now you have to, because the patients will ask you, especially 65-year-old, a robust 65-year-old will ask me, how long is this valve going to last? Because the surgeon said the valve he's going to put in is going to last for 15 years. So you do have to tell them that, yes, you might need a valve in valve, or you might at some point need an explant. And at 75, you might be getting surgery. We don't know. So we don't have that data 10 years out. Surgical literature definitely has more data for valve durability. So you have to factor that in. I think it's unfair if you don't tell the patient.
Also, there are certain infrequent,
If I can make a comment, I think everybody raised this issue. In the 2 randomized trials in low-risk patients, less than 15% of the patients were below 65 years old. So there's issue of long-term studies of this new generation of tissue valve, or TAVR, in younger patients. But also, we shouldn't eliminate the mechanical valve. Like 2 months ago, Dr. Kinney sent me a patient with bicuspid valve who wanted TAVR versus surgery. Then he really didn't want to have surgery, so he went for a second opinion to Mayo Clinic. At Mayo Clinic, at the age of 62, they told him SAVR with mechanical valve. So even at Cleveland now, around the age of 60, they're pushing more for mechanical valve. This is not the culture of our institutions among the TAVR teams and the heart surgeon and cardiologists. We shouldn't forget, it's still about 20% of the market in patients below age of 65, it's mechanical valve.
Any reason why he didn't go for Ross, that guy?
The Ross is something very specific to Mount Sinai. I mean, in the rest of the world, we don't talk about Ross operations unless you're in your 20s.
Dr. Fuster, do you have any input on this, complication that we are discussing about TAVR? What would you tell the patients that you are seeing? And then we will move on to valve degeneration. Yeah.
Well, let me touch into one point being discussed. And these are the patients with low risk and severe aortic stenosis. You cannot rely on the trials, the partner trial and the Evolus low risk trial. Why? Because 50% of the patients were excluded. And these patients that were excluded, either they had a monocasp or a bicuspid valve, they had severe coronary artery disease, aneurysm of the ascending aorta, then mitral and or bicuspid disease. That's on one hand. So we have to be very careful talking about TAVR based on the trial, especially with low risk. And I think this is one point I want to emphasize. But the second issue, these patients may need a pacemaker with the TAVR. And in addition, we don't know the long follow-up, as we said. So at this moment, if I face a patient at the age of 75, or let's say less than 65, and requires aortic valve and is a relatively low risk, I might consider either a bioprosthetic valve, surgically speaking, or I might consider a ROS procedure if the patient is not young. But let's be sure that we don't take the trials in the literature as the guidance to us, because we are wrong.
Okay. Just to highlight, bioprosthetic valve, the recent classification that came out, non-structural, which is, leak versus patient prosthetic mismatch, reversible deterioration, which is thrombosis, endocarditis, and this is where I think we are talking about structural valve deterioration, which again, they have various ways of describing. I think for us, when we see the patient, for all the cardiologists who are out there, for the fellows out there, what is it that defines structural valve degeneration? Because we see this patient at 30 days, we see them at 1 year and yearly. So essentially you have to know one thing, that the mean transvalvular gradient of greater than 20 based on what we left. So it's very important. The day of after the procedure, we have an echocardiogram. Usually we leave a gradient depending on the valve, could be less than 10 if it is supraannular core valve, or maybe if it is just about 12 to 14, maybe in the sapien valve. So very important, what's the baseline gradient, and then you follow them at 1 month and subsequently 1 year. So this is the number that you need to keep in mind that when you see these patients and the outpatients. Going to the most important point is that who should be getting SAVR in 2021. Before we do that, I just have a couple of cases that we will go through, and maybe we get everybody's input. So this is a 68-year-old female. Of course, has symptoms. If you see here, SVT ablated and medication. So EF 60, moderate aortic calcium, and this is what echo said, possible bicuspid, okay, and severe AS. If you see here, so when we are doing AS study, mean gradient of 40. Just remember that. Mild to moderate MR and normal coronaries when patient got a cath. And this is, if you see here, moderate calcium, but rarely it's opening. Look at the nice envelope of more than 4 meters per second there. And based on the CT, I think what we are seeing, the evaluation here, and I will go through why it is important. Because patient is young, they said questionable bicuspid. You see the raphe that is united, but not a lot of calcium. And the groin is just okay. What is the groin number you are looking for, which is about 6 millimeters?
Yeah, now we are doing 5.5 is a safe number. But we've done cases with 5.0 and 4.5 with an angioplasty. So 5.5 without calcium is a good access site.
So the number which is out there is 6 millimeter you want without calcium. So you're saying if it is less than that, we always take it, but that's very important. And also, which we never discussed, which we will be paying attention to, is the height of the coronaries. Very important that depending on the age, this is another important factor. When they're younger age, if the coronary height is very low, we will probably say the risk of coronary obstruction doing TAVR maybe should be going for a SAVR. Here, the coronary height was good, and same. Now, what is the anatomy that we are looking for? Patients with aortic stenosis, if it's bicuspid, young, that patient is coming to us saying that, patient, I want TAVR rather than SAVR.
Yeah, so you can see this is a nice image here on the right side, right upper side. Sahil can comment. Oh, can you go back to the next slide? Yeah, Sahil can comment. So you see we draw a little box there. So that box represents a balloon expandable valve, and the patient is going to ask, well, if I get the TAVR now, can I get what's going to happen later on? And by looking at that, based on this particular anatomy, we believe that another TAVR is likely to be feasible because you can see the box, the top line is below the corner. So you're not going to block up the corner with a second valve. The other thing we look at, the middle panel, is that raphe on the kind of 2 o'clock position there. If it's heavily calcified, that's going to be a problem with the TAVR valve in terms of PVL and risk of rupture. So we looked at that and then we discussed the patient.
Okay, so this patient actually, TAVR versus SAVR. What would the panel say? SAVR or TAVR?
I mean, it's a bicuspid valve, young patient, healthy. I would go with SAVR with a tissue valve.
I agree.
Same.
Yes.
The other thing, AK, for bicuspid, if you go back one image, look at how elliptical the bicuspids are. Your valve is circular and the annulus is elliptical. So risk of PVL is high in bicuspids. Also, you can't oversize bicuspids because they have aortopathy. Risk of rupture is high. So whatever sizing you do for normal annuli, you undersize for bicuspids. Especially young patients, you can't leave them with PVL. There's also some data risk of stroke is higher with bicuspids. So you have to think about those things. And such an elliptical bicuspid valve, you're not going to have a very good seal. So especially with these two valves available, Lotus was a different ball game. Lotus valve was not approved for low-risk patients, but in high-risk patients with bicuspid valve, it has excellent results. But
also, the data shows that pacemaker rate's been higher. In fact, the most recent paper is about 11%. So it's for bicuspid specifically, either valve. There was a CIRC paper that compared the two different valve types.
Dr. Sharma.
No, but I think taken everything together, it goes down to patient's choice also. I mean, 68-year-old, now 60, 65, probably different. But many times patients come. The problem is to convince them that no, you need surgery, rather than TAVR is more difficult. And then they'll find another center.
Yes.
Yeah.
Somewhere. So now in this particular case, I would say tend for surgery, that's recommendation, but at least the TAVR is not contraindicated.
Correct.
Some of the bicuspid aortic valve, TAVR is kind of contraindicated, so it's not in that group here.
So, like he mentioned, anatomy is suitable for TAVR. Okay, not heavy calcium. I think that's what I needed to show you. This is that came out. That if you see here, the red zone where there's calcified raphe, calcified leaflet. This is bad news. If you have this patient, look at the all-cause mortality, about 25% or so, if they get TAVR. So this patient falls in this particular group. The raphe is fused, no calcium, so likely the outcome is good. And like what we discussed, right now we know everything has been approved for the bicuspid, but heart team discussion, everything depends on the heart team. Every patient, all patients are not the same. Now this is the one that we are discussing, which is severe, where you have calcium of the raphe is fused, calcified raphe, calcium in the leaflet. This falls in that group where you should probably tell the patient you are not a suitable candidate for a TAVR. And this is what we discussed, that bicuspid versus tricuspid valve, the pacemaker is slightly higher, stroke is also slightly higher. So we need to take all this into account when we discuss with the patient. And I think, like Dr. Sharma mentioned, this patient was aware of all that, and the anatomy was suitable. It is not that it was high risk. Anatomy was suitable. Patient wanted a TAVR. Patient got a TAVR in that case. This is a second case of just showing here is a different case where we have is a bioprosthetic aortic stenosis. Okay. Look at the age of the patient, 72, lot of comorbidities. Also patient had a concomitant another valve disease, severe TR in this case. So bioprosthetic valve, again bioprosthetic valve is same that your peak and mean gradient was high in this case, and anatomy was one thing we needed to tell you here. If you see here, CTA was okay, but a low left main height. Okay. And what studies have shown that bioprosthetic valve in valve, the risk of coronary obstruction are almost higher than when you're doing it for the native. So because of that particular reason, this patient actually was sent for the surgery only because of the risk of left main obstruction in valve. So, giving you some scenarios is not that every case. This is one case that went for SAVR. Now, this is another young patient here who had, concomitant CAD. Young guy, 59-year-old, no other comorbidities, and straightforward. Significant aortic stenosis. No issues with the, CTA. What would you do in this case?
He's young, right?
59.
Yeah, 59.
Talk to the patient. He
But
has,
Louis, I'm a fan of Frost. But
yeah. Right, we have to
Dr.
discuss
Fuster?
it.
I don't know if I captured the patient, but it seems to me it's a TAVR case. Question is the
Low risk. Anatomy favorable for a TAVR, but
Right.
59-year-old.
Yeah, I think go back to the previous slide again. I think that's what the heart team looked at all the time. Looking at that middle figure on the top, look at that box again. So we always draw a box for the reason we can tell the patient, can you get another? Because this patient for sure, either surgery or TAVR would need another reintervention down the road. And so the question is, if you do TAVR now, are you going to commit yourself to surgery? Let's say 10 years, right? Because the patient is 59. And looks pretty favorable. I mean, again, this is a theoretical assessment. It's not an actual assessment. So we actually have to discuss the patient. And also, this patient, if you look at it, it's going to be a 23 transcatheter valve. So surgical valve might be a 21. So we have to talk about positive patient mismatch as well in terms of that discussion. So we go into that. And of course, it's a trileaflet valve. The patient will also have a say as well in terms of, as Dr. Sean mentioned.
I think this patient,
I would consider, here I would consider a Ross procedure.
Ross.
it's just mismatch.
59,
Because,
yeah.
because you give them a root from the pulmonic tomograph that will negate the prosthesis mismatch.
Dr. Filsufi, how often do we do root enlargement in these cases in our institution?
We don't do often root enlargement across the country. I mean, there are maybe a handful number of publications, but I don't know exactly the dimensions of the root or the body mass index of the patient in terms of patient prosthesis mismatch. But it's something often you see. Most of patient prosthesis mismatch are seen in elderly women with large, body mass index. That's the large number of patients.
Dr. Kinney, can I ask so when you do a Ross procedure, what are the options?
okay, later. So now this is what I think we have data at 5 years, okay, saying that the valve is still good up to 5 years, just to show that. Just to give you what is, that is the STS data out to say, currently the TAVR volume, this is the yearly volume, about over 70,000 procedures being done, 2019. Number of centers, over 700. And if you see here, you will see that 30-day and 1-year outcome. Everything in hospital is about 1.3 and about 2.5 or so at 30 days. And as we know, it started with extreme risk, intermediate risk, and now low risk numbers are going up. And we already discussed the access site has to be femoral. So 90% of the access site is femoral. This is the publication as of 2021. And the volume of TAVR versus SAVR, if you see here, SAVR volume is going down and the TAVR volume is going up all across United States. So the most important point, I think after all this discussion, who should be getting SAVR in 2021? So this is where I think let's ask the panel, what do they think? Low to intermediate STS risk with extensive and complex CAD. One thing that we did not touch is that with these patients, when they undergo CA or coronary angiography, low risk and significant CAD, I think everybody will agree patients should go for SAVR. Now, bicuspid valve we have discussed extensively, saying that a majority of the patients with bicuspid will go extensive heart team discussion. If they have a hostile anatomy, which I went through, should go for surgery. If all depends on the patient, a discussion with the patient. If it's something TAVR possible, you can consider TAVR. Young age, what we are talking, like Dr. Filsufi mentioned, you have a 55-year-old with bicuspid or whatever, consider that. Concomitant aortopathy, okay, that if there's concomitant aortopathy that needs to be taken care, should go for surgery. LVOT calcium, which we discussed, both annular as well as LVOT calcium, where we know there's a risk of rupture. Doesn't matter, 75-year-old, we need to tell him there is a risk of rupture, and this is something, a rare complication, but can happen, should go for surgery. And bioprosthetic dysfunction, which I showed you a case where we know the risk of coronary obstruction is very high, and this kind of things. Low coronary height and too small, too large annulus, which you already discussed, should be considered for surgery. And concomitant, other valvular diseases, which could be mitral valve disease or tricuspid valve disease. Is there anything else anybody wants to add?
One question that I have is patients who are low risk, let's put around 60, forget below 60, but they have left bundle branch or trouble in conduction. Do you consider them more for SAVR versus TAVR because the rate of pacemaker is higher, or no, you don't take that into consideration?
That is, I think we don't take into consideration. We will tell the patient there is a risk of a pacemaker. There was one case I remember seeing in the patient, same at 65, there was a risk of pacemaker, did not want it opted for surgery. We discussed that, underlying bundle branch block. I think that's one important point Dr. Fuster mentioned, that when he sees patient in the office, you look at the EKG. What is the EKG show, which is very important to describe the risk of a pacemaker in this patient. So just the emerging indication for the future, if you see here, patient with moderate to severe AS, most of the things we have discussed here. So valve-in-valve right now is approved for high-risk patient, but low and intermediate risk is undergoing randomized controlled trial. Bicuspid definitely yes, again heart team discussion, and we say who should get it. Low flow, low gradient AF, we know that. Now this is one thing that is questionable, where the EF is normal, which is paradoxical AS. We think TAVR is not even TAVR, even SAVR, we are not sure. And then alternate access, if you there are some studies going on, carotid studies, and the ongoing trials, which in the very early part of today's discussion I did mention about asymptomatic. So early TAVR is for asymptomatic cases based on the recovery trial of the surgery, where it said that asymptomatic patients, if they have significant AS, should get surgery. So that trial is ongoing, unload trial is ongoing, and of course watch TAVR for AFib. For next question, which I know will come, is what will you do if they have pure AI? There are several trials that are ongoing. Going on to antithrombotic therapy post TAVR, I think this is very important trial which was recently discussed, published. We have extensively discussed here, popular TAVI. So the background was essentially lack of evidence, combination of low dose aspirin and thienopyridine is discussed in this patient post TAVR. And so other thing is, so based on that, they wanted to see patients who will be, cohort A was patients who were getting dual antiplatelet therapy without the need for oral anticoagulation therapy. Patients who need oral anticoagulation therapy, then what do we do with this kind of patients? That was cohort B. Cohort B was first presented, essentially showing that patients who got oral anticoagulant therapy alone versus oral anticoagulant therapy plus clopidogrel, if you see here, that had the highest risk of bleeding with both the combination, that it is not good to give the combined medication. Then cohort A was aspirin alone and aspirin plus clopidogrel combination, and even that showed that the combination was bad compared to just giving aspirin alone in this group of patients. So I think coming to the last couple of points that I think we can ask Dr. Fuster, what does he feel in this group of patients, what we should be doing, because he's big in antithrombotics.
Well, first of all, the paper, the last paper that was presented, the popular TAVI, I think this paper is quite important, and I don't see the future of aspirin as is the present. The incidence of bleeding was very significant, and there was no difference in terms of the strokes and other events. So I think today, based on all the information, and I talked this to Dr. Sharma the other day because he was doing a patient of mine with TAVR, aspirin alone is the way to go, based on the data present today. I wouldn't use aspirin for people.
So essentially, I think what the point is that need that an antithrombotic therapy post who do not need long-term DAPT, very important. You need to first define, does the patient need DAPT or no? If they do not need DAPT or SAP, and no need for oral anticoagulation because there's no AFib. This is the commonest group that we find. Current recommendation is aspirin daily, lifelong, and clopidogrel we give 3 to 6 months. But what I think the discussion that's going, what Dr. Fuster is also mentioning, that will be only aspirin in this group of patients. So very important, they do not need oral anticoagulation therapy. So, we know just routine use of oral anticoagulation therapy in patients post-TAVR is harmful based on the Galileo trial. We all know that. And then antithrombotic therapy post-TAVR in patients who need long-term DAP. And go over that. Currently, we say oral anticoagulation therapy, whether it is warfarin or Novak, for lifelong with a single antiplatelet. Okay, whether it is aspirin or clopidogrel, we will decide who gets what. I think what we are trying to say is that that future will be that you consider only one of them. You don't have to give another antiplatelet therapy until we have further guidelines. Now, the question will come that you have concomitant CAD in this patient and AFib. What are we going to do? That you will give antithrombotic, and if you have to pick one antiplatelet, then you will go with clopidogrel rather than giving Novak, aspirin, and clopidogrel. We are doing actually this thing even for I would say, valvular patients. I think this is where we are. We will have this all ready for discussion amongst people who are out there as well as all the panelists. Dr. Sharma, what's the final?
So, as you just mentioned that what is current and what is future, and we had this our TVT New York Valve conference, and there this opinion was asked that how people have changed based on the popular TAVI. But again, remember it's only one trial and had not been incorporated in the guideline. So actually 70% said that they already have adopted that aspirin alone, and secondly just oral anticoagulation alone. So I think we still have continued 3 months of clopidogrel, but pending. But again, why? Because that is still the recommendation. But any case where there is an issue in terms of bleeding, thrombocytopenia, very low threshold of keeping them only single antiplatelet therapy when patient does not need oral anticoagulation. In oral anticoagulation, even in the past, we were kind of like 50-50, giving single agent. Now we actually more strongly on that point, that even while waiting for the guidelines, but majority of the investigators like us, we have changed it to single oral anticoagulation alone, because we know they all have some antiplatelet property also. I know that Dr. Fuster has been teaching that for a long, long time, and now actually this popular TAVI really endorses that. So some antiplatelet therapy or antiplatelet activity of the oral anticoagulation is always there.
Supported by AFIRE trial, which has CAD, AFib after 1 year after you drop antiplatelets. Yeah.
Roxana.
Yeah, so I came on because I couldn't just continue to listen to this. By the way, the fantastic forum to discuss these types of things. But on the antiplatelet and anticoagulation, the jury is still out. POP-TAVI is a very, very small trial. In terms of bleeding, they're right on. But POP-TAVI altogether is about 700 patients. And you know that we had to study in Galileo over 1,500 patients to start to see those kinds of harms that we were seeing, as well as there is another big trial incorporating NOAC versus vitamin K antagonists. So the jury is still out. The guidelines, we'll see how they'll approach it. I can't speak about that too much yet, but I can tell you that single trial, as Dr. Sharma said, it usually doesn't make class 1 recommendation. So I would say be judicious and make your points according to risk benefit.
Yeah, well mentioned point. I think if anybody has any questions, anybody out there in the Zoom who want to ask any questions to us?
I just, because we're running late, I just wanted to compliment you. It is so difficult to put this type of conference together, and it was great. You brought all of the latest information, and you're able to integrate all of the people. So this is really a great start. of a new mode of conference, the Zoom panel discussion. So thank everyone on the panel, and thank Dr. Kinney. We'll have to have.
Anu has done a great job.
I just want to tell you, based on all the excellent teamwork, the heart team that is at Mount Sinai, we were the first in the city to get this ACC accreditation as a transcatheter valve certification that is called. So we got to be proud of the entire team that works in Mount Sinai Heart for the valve center.
Thank you.
Thank you.
Thank you.